I'll have to find out why Colombia is spelled Colombia and Colombia is spelled Colombia. If anyone can tell me about that, I'd be more than interested in knowing. So I'm going to talk about seronegative villous atrophy. So as I mentioned before, most people with celiac disease respond to the diet. However, a certain percentage don't. And we're seeing increasing numbers of people who come along and say, I've got celiac disease and I'm no better. So as I mentioned, does the patient really have celiac disease? Was there a biopsy performed? What were the antibody tests performed? Does the patient have the appropriate HLA? If the biopsy was performed, we dealt more about the patients that do have celiac disease. Now, what about those that have a bona fide villous atrophy, but negative antibodies? This is providing, of course, that everything was done correctly and the patient had appropriate serological testing, numbers of biopsies, etc., to take that out of the mix. So here's an example of a patient that we had. This is a 70-year-old female presented with weight loss, diarrhea, and just, excuse me, I left a prop. And she had 3 admissions to hospital in which she was very sick, with watery diarrhea, dehydration, and needed dialysis on one of these admissions. Her medical history included hypertension. Part of her evaluation, she had TTG, IgA that was in the normal range, deamidated gliadin peptides that were normal, and she was HLA-DQ2. Her biopsy had been consistent with celiac disease, and she was thought to have seronegative celiac disease or possibly refractory sprue. And this was her biopsy. You can see that she's got no villi, right? They're pretty well oriented. You know, you can see long crypts in areas, long crypts. So she's got total villous atrophy. Here is a CD3 positive immunohistochemistry stain showing the intraepithelial lymphocytes are CD3 positive. Increasingly, pathologists are just doing that, I think to add to the bill, because they can eyeball it and count intraepithelial lymphocytes and say that they're increased. They often do the CD3 stain because the IHC they can add to the bill. And you can see that the epithelium has the IELs, 1, 2, 3, 4, and the epithelial cells look a bit destroyed. And also, she appears to have increased collagen deposition. And so the pathology interpretation, she had chronic active duodenitis, total villous atrophy, and collagenous change. She came through Colombia, and we agreed, rebiopsied, so collagenous sprue. So she did well on budesonide, initially 60 milligrams of prednisone, tapering down to being maintained on 20 milligrams of prednisone, that we got her off the prednisone on azathioprine. And she was doing well. And then we became aware of the sprue-like entity due to olmesartan, which is a commonly prescribed antihypertensive. So we took her off olmesartan, and the villous atrophy resolved, and we weaned her off the immunosuppressants and eventually got her off the gluten-free diet. 2 years later, her biopsy is normal, on a regular diet. See, you see lovely, like a good crypt to villus unit of at least 4 with 3-to-1 villus to crypt ratio. So we put together a group of these patients that we saw with villus atrophy and negative serologies. This was over a 10-year period in a center. All these patients were referred for refractory celiac disease, of which 70% were already on steroids. They were equal male, females, 59, but some of them were elderly, and they presented with diarrhea. So we have a checklist, and this is the final diagnosis we give. Unclassified sprue, seronegative celiac disease. Now, to get a diagnosis of celiac disease in this setting, you've got to have both the appropriate HLA and a response to gluten withdrawal. Autoimmune enteropathy, common variable immunodeficiency, drug-induced enteropathy. And we, over the years, have seen all of these patients, all of these drugs causing villus atrophy. The two most important are mycophenolate in people who have had transplants and olmesartan. Tropical sprue, bacterial overgrowth, collagenous sprue as a separate entity, Crohn's disease, infections, and lymphomas. And the final diagnoses in these 72 patients were, no, this was as we were doing this paper, right? So we had unclassified sprue, seronegative celiac disease, collagenous sprue, autoimmune enteropathy. Now, to get that diagnosis, you've got to have positive anti-enterocyte antibodies. Giardia, 3 patients already on steroids for their giardia. An unusual CD4 positive lymphoma. Bacterial overgrowth, tropical sprue. Sorry. We had some patients that presented with medication-related villus atrophy. And these people were on mycophenolate, Crohn's disease, and one patient that had total replacement of the small bowel mucosa with gastric metaplasia. Then Joe Murray's paper came out. And interestingly, this was recognized by him, being an astute clinician, because 2 patients in a row said, I keep coming in with my bad celiac disease. They stop my medications, and then when I go home, they put me back on those blood pressure medicines. So we, after identifying these 72 patients, which ones were taking olmesartan, it totally changed the classification of our 72 refractory celiac seronegative patients, in which seronegative celiac disease was the most common, but medication-related villus atrophy was the second most common that we've seen. And this is all olmesartan with some mycophenolate. Unclassified sprue, CVID, autoimmune enteropathy, giardia, etc. So it's very important that you review these biopsies because with a pathologist that you're familiar with, because the patient's diagnosis may stand out, especially these very unusual lymphomas that can be occult. Crohn's disease, we may see granulomas. One needs to get a drug history, travel or residence in the tropics. We would do HLA-DQ2 or DQ8 because if it's negative for all the alleles, celiac disease is excluded. Anti-enterocyte antibodies, Now, I don't know if they're available here because they're done at Children's Hospital in Philadelphia. They're done in 2 places in the United States, at the Mass General and at CHOP in Philadelphia. But our samples go via the Mayo Clinic to CHOP. Anti-enterocyte antibody. The pediatricians are more familiar with this autoimmune enteropathy than adult gastroenterologists. We'll do quantitative immunoglobulins, looking for common variable immunodeficiency syndrome. Now, to diagnose that, one requires at least 2 low levels of immunoglobulins, typically IgA and IgG, or IgG and IgM, together with a past history of infections. Then the patients will be tested with vaccinations like a Pneumovax and see if they have an appropriate response. We'll do breath tests because you can see that small bowel bacterial overgrowth is actually a cause in these group of patients. And just by itself, that will cause a villous atrophy, and patients can be very symptomatic. It's difficult to know what to treat small bowel bacterial overgrowth with because it can recur, and one needs at least 2 antibiotics used usually sequentially. We did not routinely test these patients for HIV, but it should be done. And, just having a checklist and ruling out Giardia saved people because they had already been put on steroids for refractory celiac disease, and it was Giardia. So it's just this important issue of having like a systematic way to evaluate all these patients. Now, what about the outcome in these patients? Of these 72, 2 of them died. 1 of them had transformation of this CD4 positive non-Hodgkin's lymphoma. Now, this is a very rare small intestinal lymphoma of which patients go on for 10 to 20 years, and 1 of them, whom we've been following for 15 years, transformed into a very aggressive lymphoma. And the patient that had total gastric metaplastic transformation of the small bowel also died. 2 of the other patients went on to develop lymphoproliferative disorders, but the majority of them had a good response to therapy, especially the specific therapies for bacterial overgrowth, Giardia, and cessation of the drugs. The management of hypertension is very complex, and physicians often change the medications. Recently, the FDA has required all drugs that contain olmesartan to have a black box warning of them for this severe diarrhea. It's hard for them to document this, but with the Mayo Clinic experience and our experience, that was partly instrumental in having the black box warning on this drug. It's interesting that 2 of the patients that we've followed with olmesartan induced very sick seronegative villous atrophy, while on a regular gluten-containing diet, appear to be developing now bona fide celiac disease. In the 2 of the patients that I'm following have developed low-level TTG and deamidated gliadin peptide antibodies. They have not as yet been rebiopsied because I'm waiting to find out. And recently at the Mayo Clinic, they've identified a patient with another angiotensin receptor blocking antihypertensive drug that appears to have this sprue-like enteropathy. So I think it's something that we've all got to be cognitive about, and in fact, I'm suggesting the patients with celiac disease not take these kinds of medications. There are a host of other antihypertensive drugs that can be used, and exploring the mechanism of the disease in these individuals might give us more insight into the development of celiac disease. Overall, patients with unclassified sprue have a very good response to immunosuppressant drugs. Once again, we'll use budesonide, prednisone, and azathioprine. And we can wean these patients down, and several of them are taking like 1 budesonide pill a day. And so we'll progressively get them off the steroids. And the other tremendous thing is that we can actually get a lot of these patients that were initially labeled as having refractory celiac disease off their gluten-free diet. So the take-home points about this are that not all villus atrophy is celiac disease, that you do require this systematic evaluation to identify causes. Drug-induced villus atrophy may be much more common than we really consider. And making a correct diagnosis allows correct therapy. And what's very appealing, because we have a little bit of a reputation, like if you go to Mount Sinai, you're going to develop Crohn's disease. If you go to Colombia, uptown, you develop celiac disease. So it's very good for us that we actually do identify patients that we can withdraw the gluten from. So thanks very much, and I apologize, Maria, for being too fast.